Hi everyone, my name is Kellie Peyton and I'm doing my presentation over the case study, Ethically Designing Research to Inform Multidimensional, Rapidly Evolving Policy Decisions, Lessons Learned from the PROMISE HIV Perinatal Prevention Trial. And PROMISE stands for Promoting Maternal Infant Survival Everywhere. So to give some background on the PROMISE HIV Perinatal Prevention Trial, the goal of this trial was to determine the best way to treat HIV-positive mothers. So they wanted to determine if shorter treatment duration versus lifelong treatment affects the mortality rate and clinical outcomes for mothers suffering from HIV. And we know that both ways are effective in preventing transmission of HIV from the mother to the fetus, but we don't know which way is safer and which way leads to better health outcomes for the mothers. The study was conducted on mothers in developing countries, and the lifelong treatment option was the current recommendation of the World Health Organization at the time. The trial was also randomized. So the sponsor of this trial was the International Maternal Pediatric Adolescent AIDS Clinical Trials. And if you go to their webpage, on the homepage, it tells you their mission, which says, "Our mission is to significantly decrease incident HIV and HIV-associated infections, and to decrease mortality and morbidity due to HIV and HIV-associated infections and comorbidities among infants, children, adolescents, and pregnant/postpartum women." So the goal of the sponsor aligns with the goals of the study. And now I'm going to tell you about the methods used in this study. So they selected women during or after pregnancy that met the following criteria. They had to be from a region where formula feeding and administering HAART postpartum is customary, and they had to have a pre-HAART CD4 plus cell count greater than 400 cells per millimeter cubed, and a screening while they were on HAART, CD4 plus cell count greater than 400 cells per millimeter cubed as well. Subjects were counseled to continue HAART as normal until randomization occurred, and by normal, they are inferring that subjects were to continue the treatment they were already receiving as recommended by their physician. Also on this, HIV invades healthy CD4 plus cells and uses their machinery to replicate, then destroys the cells. And HIV patients don't start receiving HAART until their CD4 plus cell count gets below a certain threshold, with the exception of pregnant women who are treated to help prevent transmission from the mother to the fetus. So in this study, the women picked were women who would not have normally been receiving HAART at the current state of progression in their disease. The screening of the subjects to make sure that they meet those criteria occurred in the third trimester, and the subjects were randomized 0 to 42 days after the pregnancy outcome. So more on the methods. The participants were randomly divided into two groups. So Group A continued the HAART treatment after they gave birth, even if their CD4 cell count did not meet what is typically demanded by protocol in order to receive the treatment. And Group B, they discontinued HAART after the baby was born and then resumed when the protocol demanded that they would typically be receiving the treatment. Measures were taken up to 84 weeks after randomization of the last participant, and the measurements taken included screening, entry, and post-entry visits. These occurred 4 weeks, 12 weeks, and then every 12 weeks after that, up to 84 weeks after the randomization of the last participant. And they were given physical examinations, clinical assessments, and had blood drawn. The results of this study consisted mostly of statistics. So the first statistic I want to talk about is the mortality rates between the two methods. When the mothers continued HAART after they gave birth, 2 out of every 827 of the subjects died, and when they stopped HAART, 4 out of every 825 of the subjects died. So this makes you think that maybe continuing HAART is more effective at preventing mortality and possibly the safest and more effective method, until you look at serious adverse events, in which those who continued HAART had more serious adverse events than those who stopped HAART. And for other not serious adverse events, you have a very similar percentage between the two methods. So to give an overall conclusion of the results, the mortality rates were higher for subjects in Group B, the ones that stopped HAART after pregnancy, but the serious adverse event rates were higher for subjects in Group A. And overall, the statistical evidence and results were inconclusive and didn't really give any guidance into which method was safer and more effective. And because these results were inconclusive, they didn't receive any more funding by NIH because they no longer saw a moral reason for continuing the study. So the conclusion of the case study was that although the results were inconclusive, the study was morally permissible and important. Part of the way into this study, there was a lot of controversy surrounding the ethics of this case because the treatment given to half the subjects deviated from the WHO guidelines. So the sponsor, Impact, engaged in an international ethics panel that addressed how relevant the study was and if subjects were receiving the correct standard of care. The conclusion of this panel was that the study was indeed ethical and relevant because both treatments offered were already proven to be effective, but comparing which method was more effective is important in establishing the rapidly changing guidelines on the standard of care for HIV-positive pregnant women. So some notes on the relevance and future direction that can be gained from this study. As we've learned throughout this semester, ethical guidelines for human and animal research studies are always changing and evolving. And in this case, there was a dilemma about whether it was relevant and helpful to compare two methods that were both known to be effective previously, even though one method was thought to be the safer one. The conclusion was that it was relevant, and I believe that the controversy surrounding this study will serve as a guideline for future studies that have similar goals, that is, to compare two effective methods head-to-head in determining the ethicality and relevance of these types of studies, especially in the face of still evolving guidelines. So one article I found that talks about this study was titled, "Is a Study of HIV Treatment for Mothers in Africa Unethical?" And it talks about why the study was attacked and others' concern about the possibility of providing subpar treatment to the subjects. And it also talks about the goals of the study and how the treatment option B did not adhere to the World Health Organization guidelines on how to treat HIV-positive pregnant women. The article concludes that this study is helping change the treatment of HIV in Africa, saying that the lifelong treatment option was not available to people in African countries before it was conducted, and it commends the study for its community engagement and emphasizes why it's important to involve the community the study is being conducted in so that they can see the potential benefit. The second article I found was HIV Trial Attacked, and this article was actually referenced in the first one I talked about. It argued both sides, talking about how it was useful and relevant information to simplify HIV treatment and make it available to a broader range of people. But it also talks about the viewpoint of those attacking it who claim it is inconceivable mothers would provide informed consent to participate in a trial where they may not receive the best care. My personal analysis on this study is that I was skeptical at first because it didn't follow the World Health Organization guidelines on how pregnant HIV-positive women should be treated, and it was conducted in developing countries on at-risk populations. But the more I looked into it, I found that it really didn't have any ethical issues. Both types of the treatment were previously shown to be effective in preventing transmission, and the guidelines were already in a period of change. And after reading the articles, I realized how important it is that these studies be conducted in developing countries so that you get an adequate amount of community engagement in places where healthcare and treatment for HIV is not available to everyone. So conducting studies in places like this helps that become more standardized and can help the best option of treatment become standardized in that region. And this study also met the need for clinical data comparing the two treatments because there wasn't any other studies that had already been done that compared which one was better and which one was safer. Here is a list of the references that I used to make this presentation. Thank you for listening.